Good evening, everyone, and welcome, or good morning to some if you're joining us from other parts of the world. It's nice to have you here tonight. I'll be introducing Dr. Wood in just a moment. We just want to welcome you for the webinar of Zero to Baby, the Untold Story of POF and POI, brought to you by Gen 5 Fertility. So it's my honor and pleasure to introduce Dr. Samuel Wood. He is a unique fertility specialist and scientist. He was voted one of the top doctors in the U.S. by U.S. News and World Report, America's top doctors in Castle Conley, and rated superb and super doctor. He is the only fertility specialist in the world honored as the who's who in the world and who's who in America and the who's who in science and technology, and the recipient of the Marquee Lifetime Award, Achievement Award, and the 50 People to Watch. He is also certified as a high complexity laboratory director in molecular diagnostics, and he's the director of a reproductive genetics lab who does PGT testing. He is also featured in the New York Times, the BBC, Newsweek, and over 100 television and radio programs. He's a specialist of infertility clients with low prognosis and many unique techniques and protocols that we'll be learning about tonight. He uses many special techniques, including the platelet-rich plasma, INPLAF, Ultra, and Ultimate, to enhance fertility under challenging circumstances. He does active research programs with many scientific publications over the past 3 years. He is the medical director and president of one of the leading fertility centers of the world here at Gen 5 Fertility Center. Dr. Wood, welcome.
Let me see here. Let me make sure that I get this set up right to begin with. So I need to share a screen, because the truth is that all of us that are doing anything significant in our life had a very low chance of ever successfully accomplishing that. And so there are two areas of infertility. I love all areas of infertility, but there are two areas that really, really touch me. And one of them is women in their 40s who are routinely told, you have no chance. Use an egg donor or go home. That's very sad to me. And I've spent years attacking that problem. And then there's another one that means a lot to me. I learned about this many years ago, and I've spent many years trying to improve the techniques that are used to help women who have POF or POI. POF and POI are disastrous diagnoses. Many times, a woman is in her late teens, 20s, early 30s, and she's told, you have no chance to ever have a baby. That is a horrible thing to tell a woman. And so I'm very pleased that we have developed techniques that work extremely well for it, and I'll describe them tonight. And I'm glad that there's real hope for women with that. In fact, one of the women who works with me many years ago, she had that, and I helped her have a baby. And then in the course of that pregnancy, her POF reversed. So after breastfeeding, her periods came back and her fertility was normalized, and she went on to have more children. So this is something that can be attacked. And the vast majority of women, certainly if they're, let's say 35 or under, can succeed if everything is done right. But they're routinely told they don't have a chance. So tonight is about what you can do to overcome this terrible problem. And we do it routinely. Every week, we see more women that have this. In fact, yesterday afternoon, I was in a meeting, and then I was told that a couple had come in the office and wanted to see me. And I went out and I met them. And this is a physician couple. And they told me, I'd never met them before. They told me, our daughter came to see you last year. And I said, well, tell me more. It turned out that when she was 19 years old, she stopped having periods, and she went to see her physician. And her physician, after looking at her hormone values, told her, I'm sorry, you will never become pregnant. You will never have a baby. Well, she was going out with someone at the time, And she told her boyfriend, I don't think we should stay together because I will never be able to have a baby. And I like what this guy said. He said, look, I love you. It's okay. We'll stay together. So I didn't meet her until she turned 25. And that was last year. She went through our protocols and she followed the things that we suggested. And I found out yesterday that she was pregnant. And I'm thrilled for her. I really am. This is someone who was told you have no chance. Forget about it. Someone who almost gave up on a very important relationship to her. And now she succeeded. And I hope that any of you who are on this webinar tonight who have this problem can take comfort from that and realize you have a chance too. So let's get started. So what is the definition of POI or POF? It's the loss or apparent loss of ovarian function before the age of 40. And many doctors call this premature menopause. What they're really telling these patients, look, I know you're 25, but you've gone through menopause without any good reason to tell them that. Menopause means you have no eggs left. You're done. Sometimes there's a few, but the definition is no eggs, no chance to have a baby. And along with that, they have menopausal symptoms. They have hot flashes and night sweats and vaginal dryness. And that's true of a 25-year-old with POF or POI too. So they look just like a woman looks when she goes through menopause. And when they draw blood, what do they see? They see an elevated FSH and they see a reduced AMH, which is exactly what you see when a woman is actually menopausal. Now, what's the difference between POI and POF? Well, POF means you have no periods. Presumably, you never ovulate. You don't make enough estrogen from your ovaries to have periods, to even have bleeding for many women. There's some that will occasionally have bleeding. When an ultrasound is done, there are no follicles seen on ultrasound. So again, you can understand why they're being told this. No follicles, no evidence of any eggs, high FSH, low AMH, no chance. Now, premature ovarian insufficiency is on the path to POF. So it means that you continue to have occasional periods. In fact, you may actually ovulate. But in general, what happens is it's a downward path, and eventually you get to POF and the periods stop. Now, they have low AMHs almost consistently, but sometimes the FSH is not as low. It depends on whether or not at the time the test is done, there's some ovarian function, so some estrogen is being made, which suppresses FSH. And as I mentioned, usually one leads to another. But when you have a patient with POI, that is the time to really go after it because they are generally relatively easy to help get pregnant or to at least help them get eggs so they can become pregnant later. We'll discuss that more in a few minutes. So what's the difference between menopause and POF? I've already alluded to this. Menopause, no eggs, rare eggs. POF, they're eggs. They're actually eggs there. If you go in and you do a biopsy, you take a piece of the ovary and you look at it under a microscope, you're going to see eggs. It's absolutely unbelievable. Sometimes there's a completely normal number of eggs when you look. So why do they have all these symptoms? Why do they have these abnormal labs? It's because those eggs can't get out. They're there, but they're trapped there. And the techniques that are used to help them are designed to help those eggs break free, get out, and give them a chance to become pregnant. So what's typically done with POF or POI? So the patient is seen, they have all the things that I've mentioned to you, and they say, if you want to have a baby, you can have a baby. Nothing wrong with your uterus, but you're going to need to do egg donation. Now, I don't mind egg donation. I spend a lot of my time and my effort trying to avoid egg donation for patients. But in the end, I think egg donation is actually a good thing for many women. But it's not a good thing for someone who's 25 years old, not someone who's 32 years old, someone who thinks that they really didn't have a chance, someone who looks into it and finds out they have a normal number of eggs. They say, why should I have to use an egg donor? And then the doctor says, look, you are menopausal. And as a result, you can lose bone. You can have other menopausal problems unless you take some hormones. So they put them on hormone replacement therapy, which does absolutely nothing to help them become pregnant. Now, if they're young, other testing will be done, and we'll go into that in a minute. So what causes POF or POI? Why is it that they're in this situation? Why is it that what they're told is your condition is irreversible? Your condition is impossible. And they're being told that because even though they're fertility specialists, they don't understand what's going on. This is just not taught in many fellowship programs to learn to be a fertility specialist. Now, others do understand what's going on, but it's a hassle. It is. It's a lot of work. It's a lot of caring to take care of someone who has POF or POI, and they don't want to deal with it. In fact, for them, the simplest thing would be you just agreeing to use an egg donor because the chance of success will be extremely high. So they really, really push that. So when I see patients and I see them from around the country and around the world, almost always they've been told you must use an egg donor, but they don't want that negativity. And they start looking and they find that there are some other options. So the main reason for POF or POI is autoimmunity and what's called unknown causes. Now, autoimmunity, auto means you, yourself. It's that your immune system reacts against your ovaries and attacks the ovaries. So many antibodies have been found against structures that are present within the ovary. And so what those antibodies do is they go to the ovaries and they attack the follicles, which are the structures around an egg, and they don't allow the follicle to function correctly. They don't allow it to release the eggs, even if they have a completely normal number of eggs. And so there are two problems. The first is the immunity against the ovaries, attacking the ovaries, causing inflammation in the ovaries. The second thing is that rise in FSH that I mentioned. Now, the body does not like very high levels of hormones or other components of the body. And so what it does is it downregulates the receptors. So the receptors to FSH that are present on the follicles, they're downregulated. They're taken back into the cells. And so the woman is not able to respond to the FSH that she has because it's too high. And when you give them hormone replacement therapy, it doesn't reduce the FSH levels to a point that causes the receptors to reappear on the follicular cells so they can respond. Now, there are other causes, and this is really important. These things need to be looked into either by asking questions or by doing various tests. So there are several chromosomal abnormalities that can cause this. Now, you see this primarily in younger women because when it's a chromosomal problem, it tends to occur earlier and it tends to be more severe earlier. For example, Turner syndrome. When you've lost one of your X chromosomes, instead of being a 46XX, which is a normal karyotype, you're 46X. And there are many different variations on this, small parts of the X chromosome, for example, and there's several others that can lead to something that looks like POF or POI. These are much more significant problems than autoimmunity. Fragile X syndrome, again, very common. I'm sure you're aware of Fragile X syndrome. It causes an early menopause, essentially, and it can appear to be POF or POI, but it's not in the sense that we've used it tonight. And one of the worst and one of the saddest reasons for a woman to go through this is ovarian surgery. So she goes to see a fertility specialist. He does an exam and he says, I think you have endometriosis. Now, endometriosis means that the lining of the uterus actually goes back out through the fallopian tubes, lands in the pelvis, and sticks there and causes inflammation and affects the function of the fallopian tubes. So he or she says, let me take care of this. I'm going to get rid of that endometriosis. So they go in, they do a laparoscopy or open you up, and they have one goal. I'm going to get rid of every last bit of endometriosis I see. And they go to the ovary and they see endometriosis there. And so they use their laser or their cautery and they burn it away. But when they burn the endometriosis away, they're also killing many, many eggs. And I have seen so many women over the years that had completely normal hormone levels until they had surgery. And then when the hormone levels were repeated, they appeared to be menopausal. And in a way, they kind of were, because there are very few eggs left. Now, depending on their age, there's still things that can be done. They can still succeed, but this is entirely the fault of the physician who did a surgery you don't want to do. You really don't want to have anybody doing pelvic surgery on you, with a few exceptions, if you want to have a baby. The best strategy is keep everyone away from it. Give yourself the best possible chance. Chemotherapy and radiation, it kills whatever cells, whatever cancer cells there are, but it also kills other cells. And so again, it's common to see someone who's had chemotherapy or radiation and they have very few eggs left. So these are the things to think about, in addition to the autoimmunity that I've already mentioned. But these things are less common than autoimmunity. So when you're trying to find out why someone has it, you need to take a history. For example, 10% of women actually have a family history of POF or POI. So that's a very important thing to do. And you ask questions about some of the symptoms of Fragile X. You do an exam, because some of these other causes, you will see evidence of it when you do an exam. And you also do a karyotype under most circumstances. A karyotype looks at the chromosomal complement of that particular patient. As I mentioned, a genetically normal female is 46XX. Then you do a variety of blood work. You do the usual things that I've mentioned, but you also do some other things like prolactin, TSH, which can, under some circumstances, look like the typical POF or POI. And one of the interesting things about this syndrome is that other organs are attacked as well, at some percentage of the time. For example, adrenal antibodies can also be formed. And these are a couple that we look at. We also look at some thyroid antibodies as well to see if the thyroid is involved. Now, it turns out that usually the first one you see are the ovarian autoimmunity. That's where you start. So it's important to follow up later, even if your initial test was normal, to make sure that nothing's changed. And of course, you do a pelvic ultrasound to look for things like follicles. So the traditional treatment, as I mentioned, is hormone replacement therapy. And then there's something else that doctors do that really bothers me, because in my mind, it's highly manipulative. So the patient says, I know you've told me I have no chance, but I want to try. I just want to see if I can. So they don't do any special treatments to improve their condition. Instead, they say, okay, I'll tell you what we'll do. We're going to give you some Clomid. Clomid is kind of a low-level treatment under most circumstances. We'll give you Clomid, and we'll see how you do. So they give them Clomid, which is just an oral tablet, for a week or 2 weeks, and they bring them back. They do an ultrasound, and there are no follicles. They do blood work, and there's no response. And they say, see, we told you. You have no chance. We gave you fertility treatment, and it didn't work. Now, why didn't it work? Well, remember I told you the problem is high FSH levels. How does Clomid work? Clomid works by further increasing the FSH levels. So of course it's not going to work. In fact, if anything, it makes things worse. So that is not a fair treatment. That is not a fair test for a woman to know whether or not she can succeed. And I see it routinely, absolutely routinely, and it's very sad. So What you really need to do is you need to reduce the FSH levels, not increase them, reduce them. And that allows the ovaries to respond to FSH because the receptors to FSH are now available. So what do? We strongly believe, and I guess this is me, I strongly believe in aggressively attacking POF and POI. I really do. I have seen so many pregnancies and so many babies doing this. If someone comes in, as I mentioned earlier, and she has POI, you have got to go after that. You've got to try to help her before it becomes POF, when it becomes much more difficult. It does become worse with time and age in the vast majority of circumstances. I mentioned one woman that had a reversal of it. And sometimes reversals happen, but they're very, very rare. So while you can, you want to get eggs to freeze. If you're with somebody you want to have a baby with, you want to freeze embryos. If you're with someone you want to be with and you want to get pregnant, you want to get pregnant with or without advanced fertility treatments. So what we recommend you do is reduce your FSH level first. How do you do that? Well, it turns out it's very simple. Now, we have a unique protocol here, and I'm proud of that protocol because it works extremely well. What happened in the past is that women were given a full birth control pill, or they were given a component of the birth control pill in an attempt to get the FSH level down. But the thing is, you're not just trying to get the FSH level down, you're trying to get the FSH level down to the right level so the ovaries can actually respond. And that is very difficult to do unless you do something clever. Now, what we do is we don't use just one birth control pill. We use half a pill, 3/4 of a pill, a quarter of a pill, an eighth of a pill, whatever we need to get that FSH level down so that the ovaries can respond. We use different strengths of birth control pills. We also use other things. But for reasons that are beyond this talk, if you use pills, it gives you a unique opportunity to follow how the patient is doing. In the old days, it was repetitive ultrasounds to see if follicles were growing. We've developed a new technique where you don't need ultrasounds, where you can tell what's going on very easily, very simply. And I don't like treatments that disrupt people's lives. And so the way we do things, there's minimal disruption, and yet the woman can feel at all times she knows what's going on. She knows whether or not she's responding or not responding. And how long it takes to respond can vary. You know, the shortest period of treatment that led to a baby was 10 days, 10 days. But there's only one of those, only one. The longest was 18 months. So sometimes it takes a while. Not everyone gets pregnant, but among those that get pregnant, 10 days to 180 days is our experience. So sometimes it can be frustrating. It can take longer than anyone wants. But what we're really doing here with this protocol is we're waiting for an egg to begin to grow. We're doing things to encourage it to grow, but we need it to begin to grow. And then we know when it begins to grow, and we take care of that egg, and we provide the conditions that are needed for that egg to grow and develop and become mature, and then give the patient a chance to succeed. Now, something else that we've learned is that doing ovarian rejuvenation at the same time we're doing these hormonal treatments really gives the patient a much better chance of success. So the patient that responded and was able to become pregnant after only 10 days of treatment, that's exactly what she did. She had ovarian rejuvenation. She had gone years without having a period, without any sign at all of any ovarian activity. And after she had ovarian rejuvenation, it happened. She went on and became pregnant and had a baby. So sometimes we use it with advanced fertility procedures, and other times couples say, look, we just want to try our own for a while. And we say, fine. We set up the conditions for them so they can succeed. And then we give them a chance to succeed. And very soon, we're going to be publishing a paper about 8 women who became pregnant on their own after ovarian rejuvenation. And it's really fascinating to me that there are multiple ways to get to that pregnancy, to get to that baby. Now, the next thing we're going to do is I'm going to have Shaundre discuss ovarian rejuvenation with you. I've given many talks on ovarian rejuvenation, and if you want to see some of my talks, they're present on YouTube. But Shaundre is a real expert at ovarian rejuvenation. She actually is the one that creates the specimen that's used to inject into the ovaries. So I will turn things over to her, and she will describe everything to you, and I'll be back with you in a bit.
Hello, everyone. This is Shaundre here. I'm just going to switch over to my slides right now. All right, wonderful. Okay, so ovarian rejuvenation, we're going to discuss a little bit about what the procedure day would be like and our different generations that are available here. So as you can see in this picture, it's a demonstration of how Dr. Wood does the procedure once the specimen is prepared. You are prepped in the vaginal area and cleaned, and it's just a vaginal probe. It's done here in the clinic, usually not under any anesthesia. Patients tolerate it just fine. With the vaginal probe, there's a needle guide on it, and he's able to reach each ovary through each side of the vagina and able to inject the ovarian rejuvenation specimen that's from your own autologous blood and has been processed back into the ovaries. Now, the ovarian rejuvenation, switch this over here, is used, of course, to improve poor human ovarian function and ovarian insufficiency, just like Dr. Wood had spoke of. It's for women who are experiencing these premature menopause symptoms for POI and POF, and have a strong chance of successful pregnancy after ovarian rejuvenation. So we offer 5 different versions here from generation 1, 2, 3, 4, and our generation R. Dr. Wood, of course, is always working on research, and we'll eventually have our generation 5 very soon here. But as of right now, we have found, of course, when you have a consultation with Dr. Wood, he is going to recommend a generation that would be well suited to you. Now, with the different generations, one isn't necessarily better than the other, but they're meant for different individuals under certain circumstances. And so he has found that for most women who come to us with these high FSH levels and the premature ovarian failure insufficiency tend to do well with generation 1, the PRP. It lasts for around 6 to 7 months on average for most, and gives them a chance for their FSH level not only to come down, but for them to have that response that's needed in order to get an egg. So all are designed to further increase that concentration of growth factors that you'll receive from the activated platelets. Now, here is a little bit, just a picture to briefly summarize some of the stuff that we do in the lab. We'll be, of course, drawing your blood in the morning. We'll do baseline hormones for you after Dr. Wood does an ultrasound. Then we will be centrifuging and concentrating those good platelets. Usually, sometimes incubation is involved depending on what generation and what growth factors are needed. And then we're able to process it for the actual injection. Now, when the process starts, that talks about a little bit about what we're planning on doing, separating the plasma from the red blood cells and extracting the white blood cells and the platelets. The injection process is specific to how Dr. Wood performs the injection. So back to that picture we saw, it's not only injecting through the needle guide and through the vaginal wall, but there are a few places around the world who do PRP or generation 1. Dr. Wood is very privy to the latest technology and research. It's also about the depth that it's injected, where in the ovary it's injected, how much is injected. So he always stays up to date with the latest research and technology to continue to advance in that part of the medicine, even when it comes to ovarian rejuvenation. Now, for many women who have regular cycles, this procedure is done between cycle day 2 through 8, sometimes 10 of their menses. But for many premature ovarian insufficiency and failure patients, we know that they maybe have irregular or no periods every month. And so this can be done at any time during the month for them. This is just a quick overview of what that day looks like. You only need to be here for half a day. So a lot of people travel from all over the world, of course, to see us. They usually fly in the night before at least, because they will need to arrive in the morning to get the process started. So once they have those tests and the blood is drawn, it can take 2 or 3 hours in the lab to get everything prepared. So during that time, you can even go and have a lunch or breakfast or enjoy the sunshine at the beach. And then you come back to us around noon, we prep you, and Dr. Wood does the injection himself. You'll be lying flat for about 20 minutes, and then you're good to go after that. You can actually travel home that evening. Dr. Wood does recommend that you usually want a chance for the cell rejuvenation to set in and take effect in the future cells that are going to grow. So in that case, it's usually best to wait for the 4 weeks. Sometimes we have you on pre-treatment during that time, and then we'll retest your hormones to see how things are developing and moving along for you. That is a little bit about the ovarian rejuvenation. And now I will pass it back to Dr. Wood for some further information. And then afterwards, we are going to have a little bit of a Q&A. So please be sure to type in your questions, and then we'll go from there, seeing for Dr. Wood's answers.
The bottom line is there is hope. There is hope. So if you need help, please call us. If you have questions, please call us. If you're going to see a fertility specialist, don't go to one unless they specialize in POF or POI. There are only a few of us in the country, but that's what you need. Because as you've learned tonight, you know what the other's going to say. They're not going to say things that are helpful to you. They're going to say things that are helpful to themselves. When you do an egg donation cycle, they're extremely happy about that. But that's, if you want to do that, totally fine, of course. But if you want to have a chance with your own eggs, go to someone who specializes in this. All right, Shaundre, now let's answer some questions. I think you have access to the questions there.
Yes, absolutely. So we have some questions coming through. One of the first questions is, if my AMH levels were undetectable, will this work?
Absolutely. You expect the AMH levels to be extremely low. For example, the woman that I brought up before we started, or at the start of this webinar, hers was 0.017, below usual detection levels. And the reason is that the follicles need to be active in order to make AMH. And when they're under attack by the immune system, they don't make any AMH. So normally AMH is used to determine how many eggs you have left. But you can't use it with POF or POI because it doesn't reflect the reality of what's going on in the ovaries. So absolutely, don't worry about what your AMH is. Don't worry about what your FSH is. None of those things matter. You don't know how you can respond. You don't know how you are going to respond until you actually start taking the treatment. And then you can follow along. We'll show you exactly how to do it, and you can find out what you're able to do.
Someone's fertility specialist had told them that after 35 years of age, a woman's ability to get pregnant decreases significantly, and the primary reason is the quality of the actual egg itself. They've done several retrievals with successfully retrieving eggs, but none have been able to produce embryos, and was told that it was due to age and quality of the eggs. With the Gen 5 procedure, how does that address egg quality and age, if at all?
It's kind of a crazy idea, isn't it? That at 34 years, 364 days, you're fertile. You can get pregnant. One more day, you have a birthday, and suddenly all that goes away. It turns out that when you're 35 or below, pregnancy rates are extremely high. It's almost unusual to fail. On the other hand, the vast majority of women can easily get pregnant over the age of 35. There is a small fall on an overall basis as time passes. But until after the age of 39, there's generally not much. Now, that being said, every woman is different. There's some women, as we've talked about tonight, that were under 40, under 30, under 20 in some cases, that have a lower chance of becoming pregnant without adequate treatment. If you've done multiple cycles with that doctor and you're anywhere close to 35, my advice is leave, go somewhere else, because it's just not that difficult to succeed between 35 and 39 at a minimum. There are some places that have never had any success at 40 and over. There are some places like that. But in a case like yours, I would give someone else a chance. Go talk to them, find out what they have to say about this, because I completely disagree with what your doctor says. What I found is that poor egg quality is generally based on the protocol that's done to get those eggs from you. It's not really egg quality, certainly not when you're in your 30s. That's very rare.
With the PRP or ovarian rejuvenation, do you make multiple pokes with the needle?
We do one into each ovary, and then we direct the tip of the needle to multiple locations that contain eggs within the ovary. I think that's one of the keys, is what you do when you go in the ovary. And if you just go in the ovary and just inject it in one location, you'll get a lake of fluid. It has a harmful effect. So instead, you go to the areas that have the eggs and you inject small amounts into multiple areas. But there's no reason to stick multiple times. I know in the past that was popular. Believe it or not, it used to be that instead of just having the needle go through the top of the vagina, women were put to sleep. And then a laparoscopy was done. The ovary was lifted, and there were multiple punctures made in the ovaries. That actually can increase the risk of getting scarring around your ovaries. So we absolutely disagree with that. Just as is true of egg retrievals, it's actually rare that we do more than one stick into the ovary to do an egg retrieval. We want to minimize any potential damage to the ovary. We want to be gentle with the ovary. And so, no, we don't believe in doing multiple injections except in very rare circumstances.
There's many that have asked, because they're out of state or out of country, how the monitoring and medication would work for them being out of the area.
It actually works beautifully. We have patients in Cyprus and the Middle East and all over, and we provide them with a protocol that shows them exactly what needs to be done. Now, once they have a response, once they have follicles, many of them come here. We had somebody from Dubai not long ago come to see us once there's a response. But I don't want them going and getting things that don't need to be done, things that aren't helpful to them. And so we've developed this protocol that allows them to know what's going on without doing any kind of invasive testing.
So there's many questions coming through. We thank you everyone for this. We're going to try to get to as many as we can, but we only have time for a couple more here. Dr. Wood, one of the questions asked is, do you usually recommend an autoimmune diet for patients with POI or POF?
You know, it's an interesting question. One of the things that I've done is I've joined this entity that is looking at the effect of diet on various medical issues. And I think soon they'll probably have something for infertility as well. I've given them some advice on that. The problem is knowing whether or not a diet really helps with that particular problem. And one way to look at this is we see women with very different diets that come in with POF or POI. There's no obvious relationship of your diet to whether or not you get POF or POI. Now, is it the case that a certain diet might improve the chance of overcoming it? It's possible. So it's something I'm very interested in, something that I'm looking into, and hopefully we'll find a diet that I really believe in that I can recommend to you.
Okay, just two more quick questions here. One of them was, have any POI patients tried generation 3 with the extra growth factors, and is there a difference or can it last longer than Gen 1?
You know, I love that question. I really do. It turns out that over, Shaundre, what, the last 6 months or so, patients have come in and they've said, what about doing generation 2 or 3? Because they realize the growth factor levels are much higher when they do generation 2 or 3. So we're doing kind of a not formal study, kind of an informal study about that to see if that will improve things. Because as I mentioned, one of the difficulties with any kind of treatment for these conditions is time. And if we find out that doing generation 2 or 3 can reduce the time, can help women get pregnant more rapidly, I think that would be great. So it's an ongoing study that we're doing now.
And lastly, many patients have asked on this webinar or have said that they've had issues with the visibility of their ovaries on ultrasounds, or nurses and doctors have been unable to find their ovaries. Can the ovarian rejuvenation still help them in that situation?
You know, that's rare. It is very rare not to be able to find an ovary. It's been, I don't know, years since I've been able to find an ovary. So part of it is how much experience you have and how willing you are to take a little bit of extra time to find the ovaries. Now, it's definitely the case that sometimes the ovaries are not in a good position and you cannot actually approach the ovaries. You can't put a needle safely into the ovary. But the good news is, and we published a couple of times now, that if you can only inject one of the two ovaries, you get the same effect, whether you inject one or the other. In fact, we've seen cases where we injected one ovary because the other ovary was not accessible, and the other ovary responded, made follicles, became heavier, and then fell into a position where we could get to it. Because I think a related question that's very interesting is, are there times when you're doing an egg retrieval that you can't get to an ovary? Almost never, almost never. So I think they need to take the time to find the ovary. Ovaries can be anywhere. It can be frustrating looking for an ovary, no doubt about it. But you need to know where your ovaries are and what they're doing. And if somebody can't find it, I would go to someone else with more experience and see if they can. Because as I mentioned, it's very, very rare that you cannot find an ovary if you put the right effort in.
Yes, thank you very much, Dr. Wood. And I will attest to that. I've been in the room with Dr. Wood and he has found many, many ovaries that no one else could before. So thank you all for joining us. We know there's so many great questions on here. We'd love to reach out to you. We will help answer these questions offline for you. And please keep in mind that everyone who attended the webinar tonight will also get $50 off a consultation with I or Dr. Wood, and we'd be happy to go into a great more detail with you, and especially with your specific cases. So thank you all for joining us this evening, and hopefully we'll be with you again soon.
Thank you all.